There are three main systems affected in Marfan syndrome, as you all know: the eyes, the heart, and the skeleton. And we have speakers representing all three systems today. Our next speaker is going to talk about care of eyes in the young Marfan child. Mr. Robert Henderson is a pediatric ophthalmologist and has a joint appointment between the Hospital for Sick Children in Great Ormond Street and Moorfields Eye Hospital in London. He is only one of three dedicated pediatric vitreoretinal surgeons in the country. Over to you, Robert.
And thank you so much. Thank you for that introduction. As Anne said, yes, I'm a dual-trained pediatric ophthalmologist and a vitreoretinal surgeon, and so I do pediatric retinal surgery at Great Ormond Street, and then I do, for my sanity, adult retinal surgery at Moorfields. And in terms of Marfan's, I see generally any child who has complex ectopia lentis. So we do a lot of, we're probably the largest centre for paediatric cataract at Great Ormond Street, and so many of my colleagues deal with patients with Marfan's. It wouldn't just be me, but when the lens is starting to go places it shouldn't go, then it tends to come my way. So I thought what I would do is probably talk for a little less time than Ulrich, just because I know that certainly whenever I do these sort of talks to patient information days, questions are probably as important as anything that I can tell you, because you'll probably know most of what I'm going to say. So can we go to the next slide? I have to say thank you to my colleagues, David Charteris, who are, any of you who've been on these days previously, I think he's given this talk previously, so my thanks to him for volunteering me, and my colleague Professor Chris Lloyd, who I work with at Great Ormond Street, who is probably one of the world's foremost experts on pediatric cataract, and so I have mercilessly plagiarized a couple of their talks for images and things like that. Okay, next slide, thanks. So these were some of the questions that were forwarded through to me, and I'm sure you've all got other questions as well, but what I thought I would try and do is, through my talk, answer these questions, and then anything that's left over, you can sling them my way and I'll see if I can make sense of them. So I'm going to try and cover how soon after birth the eyes should be examined, and about glasses, and what about contact lenses and squints, what do we do about that? And then, the big question that everyone wants to know is the controversial area about secondary lenses and taking lenses out and anterior chamber lenses. So hopefully by the end of that, we will have covered some of these issues. Next slide. So, I think you probably all know this inside out, but fibrillin 1, the protein, as you all are aware, is the major constituent of the microfibrils, the zonules that hold the lens in place. And so you can see on that top right slide the lens as it's disappearing off in a supratemporal direction, and you can see those zonules being really stretched. And the zonules are they're like guy ropes. They hold the lens in place, or the strings on your child's trampoline, they hold that little central piece in place. But the fibrillinopathies, the fibrillin 1 and 2, and a number of other interacting genes, so the ADAM TS-like genes, they all interact with fibrillin and another transforming growth factor beta, and that extracellular matrix, so the sort of the stuff that's in between cells, which is where you find this secreted protein, this fibrillin protein, that allows the formation of microfibrils. And so with mutations in the fibrillin gene, you get aberrant microfibril production, and so clearly the zonules in the eye are not going to work properly. Let's go to the next slide. But there are a number of problems in the eye. So it's the lens subluxing is clearly the one that everyone is aware of, but that can cause secondary problems. So the lens can go in places it shouldn't go, and either as a primary or secondary event, you can get secondary glaucomas, which is raised pressure inside the eye, and that raised pressure damages the optic nerve. You can get retinal detachments, and we can talk a little bit about retinal detachment. And because the focusing of the eye is abnormal, and probably as a result of the fibrillin 1 mutation itself, the connective tissue, you get axial myopia. So the length of the eye grows. And we're not quite sure whether it is primarily a problem of fibrillin production or because of the aberrant focusing that you get increasing growth of the eye. But certainly that's quite a significant feature. Next slide. So classically, everyone talks about the lens subluxing in a superior direction, but actually we know the lens can go off in any direction. You know, it's common, you know that. 50 to 80% of patients with Marfan syndrome have lens subluxation. And typically it happens earlier. So if you're going to get it, it typically happens in earlier childhood and becomes progressively less common the older you get. That's not to say that it can't happen later on, but it is definitely, if you get through to your teenage years and you've got not a shred of lens subluxation, you might well not have any problems at all. We'll talk about that a little bit more. And the progression again is variable. Some kids I've had slight subluxation for many years, and the lens stays roughly in place, and it doesn't cause a huge number of problems. Whilst other kids very early on have very profound lens subluxation, and I wish I could say that I knew which mutations tend to cause that, but there doesn't seem to be what we would call a genotype phenotype correlation, a correlation between the type of mutation you get and the effect. There are obviously other interacting genes or interacting proteins that affect the degree of subluxation. And you can see these bottom pictures show you some of the places that the lens can head up. So typically they go either north or south, or but sometimes they go through into the front part of the eye, which is this ancient photograph I stole off David Charteris shows you here. That's a white lens in the front part of the eye. That is not good for vision. And will cause all sorts of problems. In fact, it's become quite calcified there. I mean, I suspect that's been there for a very long time. And equally, all the zonules can break, and it can go head up into the jelly of the eye, into the vitreous. And you know, ironically, actually, a lens in the back of the eye isn't a great emergency. It can sit there for years and not cause any problems. And you know, if you've operating in Africa on trauma patients, I've found many lenses in very odd places, and actually a subluxed crystalline lens in the back of the eye doesn't cause any major issues. So let's go to the next slide. So this was one of the questions: how soon after birth should eyes be examined? Well, the first thing is, can you make a diagnosis of Marfan syndrome early? So in those of you where there is, clearly it's dominant, and therefore you've got a family history, and therefore you're going to be being screened, and you know that your child is at risk, then we would look relatively early. We would suggest seeing within the first 3 or 4 months, because a significant proportion of children will present under the age of 3. And it's important. So, I mean, I can't tell you that I have had to operate on a Marfan's child under the age of 1. I know it happens. It hasn't come to me yet, but it does happen from time to time. And it's important to recognize, because the first year, the first 3 months are what we would call the critical period of visual development. And so in pediatric cataract, if a child is born with a cataract, and that's an opacity of the lens, and they're born with opacity of the lens, we would operate, or want to operate, within the first 6 to 10 weeks of life. Because that first 10 weeks is when a child is learning to see at extraordinary rates. And the brain is soaking up all this information, and anything that interrupts with visual development, be it a cataract or be it a lens that has shifted off in the wrong place, and so you're getting very abnormal focusing, will interfere with that period of visual development. Now, do I think, therefore, that every child with Marfan syndrome, with a diagnosis of Marfan syndrome, should be examined in the first 3 months? No, actually, because I and Professor Lloyd, who I work with, have not seen significant numbers of children presenting that early. But I think if you have a diagnosis, I think an early referral is warranted. And you can see here that the older you get, the number of patients who are diagnosed with Marfan and with, at that age, with lens subluxation decreases with age. So one of the questions that'll come up later is, how often should we be examining? And if my child presents with no lens subluxation in teenage years, is that it? Are they done? Are they okay? And I think the answer to that is, if you present in teenage years with no lens subluxation, the chances of developing significant lens subluxation are definitely significantly reduced. But I would not give up going to the optometrist for annual eye checks. And that would generally be my advice. I don't think you need to come into the hospital eye service for a review, but I think an annual review with your optician, who will be able to make the diagnosis, is warranted. Okay, so let's go to the next slide. So this was a question: what age should children be prescribed glasses? Well, I mean, this is like the previous question, and the answer to that is, as soon as there is a significant refractive error that is likely to impact on visual development. And that refractive error can either be myopia because of Marfan syndrome, or myopia because of the lens changing its position, or because of, and more commonly, because of astigmatism. So as the lens shifts position, light starts to be bent unevenly between the middle of the lens and the edge of the lens. And you can imagine, if you stare through the edge of a magnifying glass, you're going to get lots of optical aberrations. And so you want to try and correct that, either with glasses or with contact lenses, early, particularly in young children. And we, commonly give glasses to babies who have had cataract surgery. So fitting glasses is not something that, at that age, is not something that your average optometrist in the high street would be doing. That's certainly something that we would do either at Moorfields or Great Ormond Street, or your local centre will have the facility to fit glasses on babies' faces. But so we're very actively looking for that, looking for significant refractive error that will impact on visual development. And if it is, then we will think about putting in glasses. Let's go to the next slide. So how do we manage it? How do we manage these lenses that are moving off axis? Well, as I alluded, mild subluxation is something that we manage with glasses or contact lenses. And we will try to preserve the natural crystalline lens as long as we think that it is not interfering with vision significantly. Because the natural crystalline lens has that ability not only to allow you to see into the distance, but also to refocus, especially as a child, not as I'm getting in near my 50s, but when you're young, obviously you can look into the distance and then look at near. That's a process known as accommodation. And accommodation is often quite well preserved, even in a lens that has quite significant degrees of subluxation. And we have to watch for it to make sure that you can accommodate. But accommodation, the ability to see at near, is really profoundly important for visual development. And so if we can preserve the natural crystalline lens in order to aid visual development, we will do, because being aphakic, being without a lens, even if you've got wonderful contact lenses or glasses, it is still very amblyogenic. So amblyopia is the lazy eye, where the brain is not learning to see because the quality of the image is poor. And having no lens, as might happen if you had your lens taken out very young, or in fact during childhood at all, especially in Marfan syndrome, you may well have glasses, you may well have bifocal glasses or contact lenses and glasses for reading, but during that first few years of visual development, it's really crucial that you have good near vision as well as distance vision. And so we try our hardest to preserve the lens until we think, this is causing more problems with visual development than good. And you can see in this picture here, here's a lens that in the dilated state, there will be quite a lot of light going through that lens and giving you a reasonably well-focused image. But there's also quite a lot of light going around the lens and giving you a very defocused image. And the brain's, pretty amazing actually at being able to select the focused image and disregarding the non-focused image. But at some point, you're getting a rubbish image overall, and the brain can't make sense of it. And then your vision, as you read down a chart or on the cards that we use when you're pre-verbal, your vision is reduced compared to what we would think of as being normal for your age. And that's a time when we can't correct you with glasses, we can't correct you with contact lenses, and your vision's going down. We think, right, we should have a conversation about surgery. So to summarize, if the lens is moving off axis, if your vision's fluctuating, if we're not able to get your vision back to what we would think of as being roughly within the normal range, then we need to have that conversation. Next slide. So at what age and under what circumstances is it recommended to remove dislocated lenses and replace them with an anterior chamber lens? And can this be done in stages? This is like a bit of what we were previously talking about, but it brings us on to the big hot topic, which is lens replacement. So as I said, we do it when we can't correct the refractive error, and when the lens is moving so much that it's causing more problems than good, and when visual development is being harmed, okay? And so the gold standard really is, especially in childhood, is contact lenses and glasses. So let's move on to the next slide. Because secondary lenses come with a whole range of issues. So we still think of contact lens and glasses as being the way that we will go, especially in young children, and especially, until the eye has finished growing, because as we will go on and see, all of the secondary lenses, and there are now a plethora of options, but they all come with their own issues that you have to contend with. So let's move on, and we'll go through what all those options are. So the anterior chamber lens, and this has always been for probably the last 40 years, the kind of standard secondary lens for a patient who has got no capsular support. So what do I mean by that? Well, in conventional cataract surgery, that bag that holds the lens in place, which is anchored in place with all of those fibrils, those zonules, that bag, we open it up with a little circle, and then we extract the lens from within that bag, and then we polish it all up, and then we insert into the bag a nice new acrylic lens, and that's good for the rest of your days. But if your bag's gone, if your zonules have all broken, you've got no support for a classic posterior chamber lens. And so we would have historically always have used this. This is an anterior chamber lens. So what are you seeing here? In fact, you're actually seeing a complication of an anterior chamber lens. So you can see there a clear lens with a pair of arms, and those are called haptics, and they are stuck into the periphery in front of the iris. Now, I don't know if you can make out in this picture, but that iris is starting to bulge round that lens, and that is something we call pupil block, and that is because behind the iris is an area of the eye called the ciliary body. It's out of the ciliary body that the zonules protrude and hold on to the lens. But the ciliary body is also there to produce something called aqueous. Aqueous is a fluid that keeps the eye pumped up and gives you pressure, a bit like a football, requiring a certain amount of pressure. And that fluid comes through from behind the iris, and it comes through the pupil, and then it drains out into the periphery, where those little arms are located. And if you block the pupil with a lens, there can be a situation where that fluid now has no means of escape, and you can therefore see it's all pushing the iris forward, and we call that iris bombae. And that actually is an acute eye emergency, because the pressure will go up very, very high, very, very fast, be excruciatingly painful, and if left untreated, will cause permanent loss of vision, if not blindness, very quickly. And so the way we treat that is to make a hole through the iris, which we call a peripheral iridotomy, so that there is an alternate mechanism for the fluid to come into the front part of the eye, the anterior chamber. So one of the complications of this lens is that you can, if the peripheral iridotomy that you make at the time of surgery closes up, you can go into this situation, pupil block glaucoma. Now, another problem with these anterior chamber lenses is that the surface, or the internal surface of the cornea. Now, the cornea is the clear dome on the front of the eye. So the internal surface is lined with pump cells, and those pump cells are finite in number, and they are responsible for pumping fluid out of the cornea and keeping the cornea clear. And so you're born with a very high number of them, and throughout your life they gently drop off, and normally you've got plenty to see you out for the rest of your days. But if you have lots of surgeries, or if you have a lens in the front of the eye, you can start to lose those cells at a rather greater rate than you might otherwise do. And that can cause the cornea to become opaque. And that's nowadays surmountable. We can do corneal grafts or partial corneal grafts and replace those cells, but it is a drawback to this lens. It's not to say that the anterior chamber lens shouldn't be used. And I mean, my own approach is that if you came to see me in your 60s or 70s, I would say, if you've got a nice clear cornea, this is a lovely, easy lens to put in. It's straightforward to use. It has, you know, you've almost certainly got enough endothelial cells to see you out for the rest of your days. And so I'll put the lens in there, and it gives good refractive outcomes after a few months and everything's settled down. So, so I certainly put plenty of anterior chamber lenses in, but I'm less keen on them when you're younger. So let's go on to the next lens. So that brings us on to a lens called the iris clip. And these have come and gone in vogue, and there are lots of different iterations. And the most common one of them now is something called an artisan lens. And you can see how this works. It's like an anterior chamber lens. It is anchored onto the iris with these little lobster claws. So you can see the iris there. It's a slightly odd blue. It's been lit. This photograph is a slightly odd one, but anyway, you can make out that there are little claws coming off the central optic, and they're pinching onto the iris there, and that's what holds it stable. And you can actually put them either on the front part of the eye, or you can turn them over and anchor them on the back part of the iris. That's called posterior iris fixation. And providing they hold on, they're pretty good. They still have the issue, especially if they're on the front part of the iris, of causing endothelial cell loss. And I can't tell you I love these lenses. Some of my colleagues use them, and they and they've used them very successfully for many years. So I'm not here to put people off having an artisan. They're not a lens that I terribly like, partly because when I look at them, the whole iris is sort of flopping like this at you. And with this lens, it just makes me feel a little bit sick looking at it. And also because they're anchored onto the iris, they tend to throw pigment cells, and that pigment cell can start to block up the trabecular meshwork. And the trabecular meshwork is that area in the corner of the eye where fluid is draining. And so blocking it up can cause, over time, glaucoma. And so they can cause problems, and they do drop off from time to time. You know, the fixation onto the iris isn't as solid as you might like sometimes, and then the lens drops and to go back in and re-anchor it. And I don't know, they're not my favorite type of lens, but I know they are used by my colleagues of mine and used very successfully. But for me, they still have plenty of drawbacks. That the same with the anterior chamber lens. Let's go to the next lens. So sutured acreus. Now I've got a video coming up, and for anyone who is squeamish, you will want to look away. But for those of you interested in eye surgery I think is awesome, and it doesn't involve too much blood, unlike Ulrich's surgery, which is So the Acryos is a lens that we have traditionally used as a normal posterior chamber lens. And you can see it's got these little arms, and it can go inside the bag and it folds up very nicely, so you can put it in through a tiny little incision. But because it's got these little eyelets, we can use a Gore-Tex suture to actually stitch it to the wall of the eye. Now, sutured lenses have had a poor history. And for those of you that have ever heard David Charteris's talk in previous years, you'll have known that the audit that we did at Moorfields of these, they only lasted about 5 years, because the suture that we used to use, which was called Prolene, used to snap, and then the lens would fall into the back of the eye, and you'd have to go and retrieve it and either resuture it or use a different type of lens. And so they kind of fell out of favor. But increasingly, we've been starting to use Gore-Tex, because the cardiac surgeons like Gore-Tex, and apparently it lasts for a long time. And it does give you a lens that is anchored beautifully in the posterior chamber of the eye, so in the anatomically correct position. And it's absolutely rock steady, so it doesn't move at all. And the anatomy and the optics all sort of are as one would want them to be. So from the optical perspective, they are really nice, but they do have a couple of drawbacks. And one of those is that suture goes through the wall of the eye and then underneath the conjunctiva, which is the clear membrane that covers the white part of your eye, before going back into the eye and anchoring round through the other eyelid. And that means that you have a permanent fistula that potentially little microbes, if the conjunctiva ever got a break in it, could crawl their way down and into the eye. And that could potentially give you an infection inside the eye. And an infection inside the eye we call endophthalmitis. And that's a disaster, because actually infections in the eye can lead to permanent loss of sight. So although I've only ever seen an endophthalmitis once, and that was in the acute phase immediately post-surgery, it does represent a long-term source of concern. And we don't know how long Gore-Tex has been used. Gore-Tex will last inside the eye. We don't know whether it'll eventually break. And we haven't got enough long-term data on it to know whether it's going to last significantly longer than the Prolene sutures. So I have put some of these in, and I put these into kids because they were sitting in a nice position, and but they come with their caveats, and that I don't know the long-term outlook for them. Okay, what's the next slide? So most recently is this lens. This is called a Carlevale. It's a lovely Italian chap who's come up with this lens specifically designed for implanting into eyes that have no capsular support. And you can see that on the end of either of this lens, on the ends of those haptics, are two little T-bar shaped appendages. And the idea is that you go in, you grab that little T-bar, and then you make a partial thickness incision in the wall of the eye, and you just put that into the little pocket that you've created. So it's suspended in the wall of the eye, and then you sew over the little incisions you've made. And so you don't theoretically have the risk of ingress of microbes through the wall of the eye. There is no full thickness fistula, but you've got a lens that sits in the anatomically correct position behind the iris, and therefore they should, if done well, last a very long time without any significant problems. Now, this is a really new lens, and I have only been putting them in adults so far, but I'm gently starting to think about whether or not this might be quite a good lens for children. What are the problems with it? Well, because it's a partial thickness pocket that you're making in the white part of the eye, the sclera, and we know in Marfan's the scleras, because of the role of fibrillin, the sclera can be a bit thinner, and because often the eyes are very myopic, and that makes the sclera thinner, you've got less material to work with to embed these little haptic, that little T-shaped flange. And so, is there a possibility of the lens sort of pulling through and coming out, or the sclera overlying it, sort of rubbing and the lens popping out that way? I don't know. I suspect there are some concerns around that. And we'll have to see. But it's certainly the first lens that has been created specifically for this indication. Okay, let's go to the next slide. And slightly out of order, but this is a technique called the Yamane, which is using a very conventional lens. And this is the typical type of lens that you might put into someone having routine cataract surgery. And it's got the little haptics, those little arms. And instead of putting them in the bag, you take those little haptics and you embed those in the wall of the eye. So that was a kind of a precursor to Carnivale. I did this for a while. I don't really like it because you get twist, you can get a little bit of torque on the lens, and then you get lots of optical aberrations, which means it's really difficult to correct with glasses. Anyway, they're still quite popular. Quite a lot of my colleagues still use this as a technique because the lenses are really easy to find and they're cheap, where the Carnivale is pretty expensive. Okay, next slide. So this is video. Video of eye surgery. Turn away now if you don't want to. I'll give you I'll give you a running commentary so you can listen if you don't want to watch it. Okay, so let's press play on this. So a big dilated eye. Now you might be able to make out that the lens, there's the shape of the lens there. I put 3 little ports that allow me to get into the eye. And I'm doing a vitrectomy at the moment, which is removing the jelly. Now here you can see the sublux lens, and I need to move it. This is going very fast, this video, but I'm removing the lens basically just by sucking it all up. I'm passing this Gore-Tex suture through the eyelets of the aqueous lens, and I'm going to fold that lens, and then I'm going to pass those sutures and hand the sutures out and pull them through the wall of the eye. Then I'm putting the lens into the eye, and I'll do the same through the reverse sutures so that they come out the other little trocars. So it's all suspended there. And then I'm just going to tie those 2 sutures off. And then you can see it's kind of like a hammock. The lens hangs there on the wall of the eye. It's got a lovely full thickness of the sclera there, so that shouldn't erode through. The suture's lovely and strong, Gore-Tex material, and then I cover the conjunctiva over the top of it, and it's done. And the operation is really quite straightforward, and the visual results from these lenses are really good, and you don't have the risk of glaucoma, you don't have the risk of endothelial failure, but you do potentially have the risk of microbial ingress at some stage down that suture tract. That's a theoretical risk, but one that does slightly concern me. Okay, next. Now, how is strabismus best treated? This is a subject for which there are huge textbooks that have been written, and I can't possibly summarize those other than to say that strabismus, which is non-alignment of the eyes, or squint as we tend to call it, not squint like that, but squint with your eyes pointing in or out, comes about because either you have an inherent weakness of the muscles, or because the vision in one eye is not very good, and therefore the eye can either drift out or in because it's not able to fix, and those 2 images won't map on top of each other in your brain, and your brain can't lock the 2 images together. And so if you have strabismus for whatever reason, the golden rules are first to try and get the vision as good in that lazy eye as you can. And so we do that with the glasses or the contact lenses, and we do it with patching. So we try and patch the weak eye in order to make, patch the strong eye, sorry, to make the weak eye stronger. Or we can blur the strong eye to make you use the weak eye more. And when you've got the vision as good as you can, then you can either do surgery on the eye, and surgery on the eye essentially is to, like reins on a horse. So you might tighten up one rein to pull the eye in, and you might loosen off the rein on that horse. So the muscle on the outside of the eye, you might set that back a bit, and that turns the eye and straightens it up. And you can do that on either eye, actually, because the 2 eyes work together, they're yoked together. So even if you have this eye turned out, I could operate on this one, and I would turn the eye to face the same way, and then the 2 would work together again. So there are lots of different approaches to strabismus surgery, and telling you which way is the best is certainly not something I think I'm probably best placed to be able to give you an honest answer to, because there are so many ways to do strabismus surgery. One other approach actually is to use botulinum toxin. So you can actually inject botulinum toxin, or various similar agents into the muscle around the eye that is pulling too hard, and that weakens it. It's only temporary, but the more injections you have, the weaker it gets, and so it lasts longer. And often we will do botulinum toxin. It's certainly in Moorfields, it's very, very popular. We too use it at basic grade Ormond Street, but probably tend to do surgery a bit more often, certainly in the children. So hopefully that gives you a very brief overview of what strabismus surgery involves. Let's go to the next slide. Oh, that's it. So hopefully, I don't know what we're doing for time. Any time for questions? Hopefully we've got a little bit of time for questions.
Well, and I'm very grateful to you. You've answered practically all of the questions that the patients sent in ahead of time. We just have one from a mother with a teenager who took him along to have his eyes examined, and the ophthalmologist said that there was no sign of dislocated lens and that he shouldn't have any greater risk than the population in the future of having this. Can you tell us if there's a particular age at which you stop worrying about dislocated lens, and should he continue to go?
So I think, as I said in the talk, I don't think that risk completely goes back to normal. It is certainly significantly less with age, and my anxiety, if I was a teenager and had no signs of any subluxation, my anxiety levels would be low. But and I don't think you need to be seen in the hospital eye service if you've got no lens subluxation. But I do think you should go and have an annual eye check with your local optician, because they're well trained by and large, and they will spot if there are problems in the lens, because it's one of the first things you see when you put your little refraction, the device that we use for refracting up. You can see the lens just looks very odd if it's off center, and so it's very easy to spot.
Thank you so much for giving up your time. And I'm sure a lot of our patients will be asking other questions, which we can pass on to you.
Yeah, that's fine. I have one more, Anne, at the bottom I'll quickly answer. As an adult with subluxation, just wondering at what stage and which type you would replace lenses with. So at an age where it's causing you problems. If it's causing you problems and you don't like the idea of contact lenses or glasses and they're just not working for you, I would happily replace your lens, and we would have a conversation about which lens type you would like. As you've seen, there are lots of pros and cons to all of them. I've tried nearly every single technique, and so I have ones that I am more comfortable with in my own hands. But it's a conversation that we would have. But you have it done when it's causing you problems.
Thank you so much.
Sorry to interrupt. I think Tracy has a question quickly.
Sure.
Yes, I do. A similar sort of question. So my son has one completely sublux lens, which is floating around in his right eye. And for a long time, since about the age of 11, he's used a contact lens in the left eye only on an aphakic prescription. And that's been fine. I mean, it's great. When this dislocation happened, we went up to the eye hospital and they were all ready to go in and pull it out, although things are quiet, and replace it with a lens. However, since the reason he's always used one contact lens is the fact he's never been able to get a binocular vision with contact lenses in two eyes. Is that something that we're likely to be able to solve? What we did with the surgery, by the way, was just leave things lie, as you mentioned at the beginning. So it just floats around. He still walks around with his left eye contact lens. But I'm just interested to know in the future. My concern was that with doing surgery was that we'd then end up, if they put in that lens, we'd end up with him having double vision and right. Being a right old pickle.
Yeah. I mean, so that is an issue because stereopsis, the ability to take two images one from each eye, map the two on top of each other, and give yourself one image. That fusion is actually really easy to disrupt, and so it's one of the first things that will go actually if you disrupt vision to one eye. Now, young children will suppress. And so if you don't have alignment of the two eyes, then they don't see double. The brain hates double vision. And so it will basically just turn off the image from one eye. As soon as you put your hand over the other eye, it flicks straight back on. It's seamless. You wouldn't even know it. But with the two together, it will prefer one eye. In fact, we all have one preferred eye. We tend to use more than another, a dominant eye. But this is a much stronger effect. Now, the question you're asking is, if we put a lens back into that eye, would he learn to suppress, or would he have intractable diplopia? Intractable diplopia is disgusting. And you almost, if you don't suppress, you have to then have either an occlusive contact lens, or you have to have something like blender, like sort of a semi-opaque tape over your lens. It's horrible. Yeah. So I would be looking to see, I mean, we would get him seen by the orthoptist. Orthoptists are the people who you see in a pediatric clinic who do all the vision and the strabismus measurements and everything. And they can assess the potential for binocular vision or diplopia. They do something called a post-op diplopia test, and they would give you an idea as to how likely it would be that we would get double vision. And I mean, it's easy enough to do. If you put a lens up in front of the other eye and he gets two images and they're horrible, then I think that gives us an indication that he's not going to do terribly well. And I suppose it then depends on how young or old he is as to whether he'd be likely to suppress it. But the older you are, the less likely you are to learn to be able to suppress.
Okay, thank you. So the sort of the issues of using like Botox to see if that would address that strabismus, he doesn't apply to that sort of thing.
So you can put a child, I mean, if they're old enough, you can put them onto a synoptifor, which is this wonderful old Heath Robinson-like contraption, which you look in, you put the correction up, and then you can put the chicken inside the cage, which is essentially seeing whether or not, if we move the image, he can perceive the two together as one image. And that allows us to be able to work out whether or not he can fuse if we straighten the eyes up, or whether it doesn't matter where you put it, he wouldn't be able to see the two as one. So these are all things that can be looked at, and certainly would be looked at before we even think about doing anything.
Yeah, well, he's 25 now, so.
I mean, certainly it's possible in adults as well, but my suspicion is that he's going to get double vision and he's not going to like it.